Quality and Safety, a Leadership Concept, presented by Miriam and Christina. Our discussion topics include CMS, never events, quality improvement, culture of safety, blame culture, and a plan to address these issues. Who is CMS? The Center for Medicare and Medicaid Services is part of the U.S. Department of Health and Human Services that oversees federal healthcare programs. The National Quality Forum issued a list of 29 events that are considered serious reportable events, also known as never events. Never events are medical errors that should never happen to a patient. These events can be easily identified and measured, serious and preventable, and are considered reportable. The CMS no longer pays for care related to these events. Medicaid and now many third-party payers have followed CMS's decision. Healthcare organizations are under increased pressure to eliminate these devastating and preventable events. Promoting continuous performance improvements by utilizing quality improvement strategies in healthcare organizations can prevent these adverse outcomes. Many patient safety improvement initiatives led by CMS are helping to make care safer for patients. CMS has set the goal for reducing these events by 20% by 2019. CMS provides intensive, focused, quality improvement assistance to healthcare organizations in an effort to reduce harm to patients. From 2010 through 2014, there was a 17% decrease in adverse events that equates to the prevention of 87,000 deaths and savings of $19.9 billion in healthcare expenses. From 2014 through 2016, approximately 350,000 never events were avoided. A major activity of CMS is driving quality improvements with the intent of changing healthcare systems to address safety and care. The CMS Quality Strategy Initiative has 6 goals, with the first and most important being to make care safer by decreasing harm that is caused during the delivery of healthcare. CMS funds and disseminates best practices for providers and hospitals and rewards them for adopting said practices. By the end of 2018, 50% of Medicare payments and 90% of all Medicare fee-for-service payments will be tied to quality or value. CMS develops, tests, and conducts patient surveys. So what is quality improvement? Quality improvement is a systematic and ongoing approach that creates measurable improvements in healthcare and health status. To improve quality, a healthcare organization must understand its own delivery system and major processes. This can be accomplished by viewing what is done and how it is done. All healthcare organizations require a quality improvement program to assess, monitor, and improve its standard of care. The Health Resources and Services Administration is vigorously involved in quality improvement. Quality improvement requires 5 essential elements for success: fostering and sustaining a culture of change and safety, developing and clarifying an understanding of the problem, involving key stakeholders, testing change strategies, continuous monitoring of performance, and reporting of findings to sustain the change. The Agency for Healthcare Research and Quality collects data on core measures for the annual National Report Card on Quality. Core measures are focused on safety, patient-centered care, effectiveness, efficiency, coordination, and timeliness. The reports provide a concrete and consistent monitoring method of the present status of healthcare quality and can be used to improve. The information can also be utilized by healthcare organizations to develop and implement educational needs for its staff. These areas require surveying to determine if efforts lead to desired outcomes. In order to prevent patient harm or never events, we need a plan of action. Since medication errors and falls are most prevalent and seriously injurious, the interventions included will focus on those 2 sentinel events. To prevent medication errors, institutions must conduct active investigations into medication errors, especially those with adverse outcomes, and this is done as a means to identify failures and processes within the organization's medication administration. The institution should discuss the discovered weaknesses with management to prevent repeat errors. Continuing education must be a priority. Nurses should adhere closely to the 7 rights of medication administration without exception: right patient, right drug, right dose, right route, right time, right reason, and right documentation. These rights were developed, tried, and found to be successful when applied regularly. Although we have decreased some errors through EHR use, it still takes an observant nurse to catch mistakes. The best predictor of a future fall is a history of a fall. In-services must be instituted by healthcare organizations to inform staff of the issues regarding falls. Why patients fall, the common causes of falls, risk factors that predispose patients to fall, and how to reduce these falls. AHRQ and the Joint Commission recommend using standardized fall assessment tools. Some examples are STEADY, Morse Fall, Johns Hopkins. Also, care plans and the implementation of interventions should be patient-specific. We should engage and educate patients on their personal risks. It is imperative that the institution collect and analyze fall data. Without seeing where the organization failed, improvements cannot be made. Never events should never happen, but they do happen. And what do we do if they do happen? The most important action after a never event is to perform an immediate and thorough root cause analysis. This provides a systematic approach for investigating the medical error. This type of analysis helps identify the factors and processes and structure, as well as the ineffective safety barriers that allowed for the negative outcome. The Joint Commission requires a root cause analysis to be performed in response to all sentinel events and expects, based on those results, for the organization to develop and implement an action plan consisting of improvements designed to reduce the repeat of these events and to monitor the effectiveness of those improvements. The risk of future recurrence can be dramatically reduced by implementing appropriate policies and procedures and protocols within the healthcare organization. Preventing these events is the driving force of NQF's patient safety efforts in healthcare. The list of never events can be retrieved from the website listed here at the bottom of this slide. We mentioned implementing appropriate policies, procedures, and protocols within the healthcare organization. So what are some examples? Well, to decrease adverse outcomes, leadership must secure a safety-conscious environment, provide ongoing education and staff training, implement a continuous quality improvement program. They must also utilize evidence-based practice in QI programs and monitor the QI's performance with weekly briefings, data collection, and analysis. Leadership must also engage all stakeholders, provide feedback to all stakeholders of QI results, standardize and simplify processes, such as implementing checklists, protocols, and assessment tools, develop constraints to prevent from doing harm, such as pop-up alerts and safety checks during medication administration. Decrease the workload of healthcare workers. Decreased ratios, distractions, and interruptions improves patient safety, especially in the prevention of falls and med errors. Leadership must also ensure access to real-time data, i.e., the electronic health record. The more we know, the better we can plan care. And finally, the creation of safety culture along with the demise of blame culture is imperative. A culture of safety exists at an organization that has top-to-bottom personnel committed to safety regardless of the complexity or perilousness of duties to carry out. It's a place where blame is not a focus and reporting errors or near errors is welcomed. It's an environment where teamwork is encouraged with the goal of solving issues. So who is responsible for safety culture? Well, nurses are, because we are identifiers of errors. We're the closest to the patient and we can easily spot unsafe practices. Organizations are responsible because they are accountable for their systems. To err may be human, but it may also be a failed system. The greatest impact is made through analyzing the system and improving processes. It is also the responsibility of leadership because leadership is responsible for creating a safe environment in which to speak up. Doctors, IT, environmental services, basically everyone needs to pitch in. It needs to be a collaboration between everyone present. Implementing a culture of safety takes training staff to work as a team, standardized handoff communication, unit-based teams to address areas such as codes, falls, and skin breakdown prevention, and blame-free reporting system. Safety must be a priority over all else. It should involve patients and be transparent. Management is obligated to communicate expectations and rationales and must both empower and equip staff to meet goals. Culture of safety is measured typically through self-surveys, and there are a lot of resources available on the Joint Commission's website. These are just a few of them. So the first one, that's AHRQ, is used to assess patient safety culture, track changes in patient safety over time, evaluate the impact of patient safety interventions. And the Premier Inc. one is a data tool used for managing results of the previous survey mentioned. And then the last one, longwoods.com, is a safety culture improvement tool. In contradistinction to safety culture comes blame culture. The consequences of a blame culture cause fear of being humiliated, blamed, or even sued. Some individuals commit suicide. Errors are hidden. Blame culture inhibits honest and accurate discussions about errors and system weaknesses, which is opposite of safety culture. Blame culture also limits lessons learned. And system errors may reappear occasionally due to lack of discovery. A distrusting environment is created between healthcare workers, patients, and families. Creating a blame-free culture gives reporters the opportunity to share incidents with impunity, leading to a culture of safety and the generation of data to assist in the improvement of process and interventions. Some people feel that without blame, errors will not be accounted for. Blame culture has the mindset that someone must pay. Of course, even in a blame-free culture, someone who acts recklessly or negligent will receive training, maybe discipline, and possibly loss of employment. Blame-free culture means errors are first viewed from a system perspective before finger-pointing. In order for a safety culture to thrive, we must eliminate blame culture, because blame culture leads to the covering up of errors instead of transparency. So how do we change blame culture? Institutions must encourage and increase employee involvement in decision-making. They must implement fair treatment of staff by management, thereby increasing trust of staff, leading to more reporting. Institutions must view mistakes as learning opportunities and discuss errors from this perspective. Management does have the biggest influence on culture. I mean, they choose what is considered fair, they build or break trust, they create or banish fear, they decide what information to share and what to withhold. However, all of us can influence change. Hopefully this information has been helpful to you and you can use it in your practice. Thank you for watching.